And welcome back to Pharm Part 3 for cardiac. Let's move on. In the previous video, we talked about ACE inhibitors. Let's look at some of the other things that work in the renin-angiotensin-aldosterone system. The next thing we want to look at is your ARBs, angiotensin-receptor blockers. Okay, so you got your nice picture of the angiotensin or renin-angiotensin-aldosterone system with all of its stuff. And let's look over here at angiotensin 2. ARBs work in the same system, but instead of blocking here, they block here. So once again, it's blocking the receptor sites for angiotensin 2 to cause vasoconstriction and sodium and water retention. So in that case, it does the same thing as an ACE. However, it may have less adverse effects. And you recognize your ARBs by sartan. Things you still need to think about are hyperkalemia. Okay, you may still have a risk of angioedema. Okay, but oftentimes if someone's having a problem with coughs with the ACEs, an ARB will help to solve the problem of the cough. So you may see sartans, or if somebody's on a prill, they may say, I was coughing and they put me on another medication. It's probably a sartan or something else. Ah, look at that. Okay. One last thing, because we're not done. Okay. The last medication that works in the renin-angiotensin-aldosterone system is aldactone, or spironolactone. And it blocks the kidney from reabsorbing sodium. It's an aldosterone inhibitor. So that's why we have this lovely circle right here showing you the inhibition of aldosterone. It is potassium sparing. Okay, it can be used for hypertension or heart failure. I can tell you that within my practice, most of the times I see aldactone, it's used more in a liver failure situation because the liver has a problem in that it will not break down aldosterone. And you end up with hyperaldosteronism. So aldactone helps to target some of the fluid retention that occurs with liver failure. So your three meds that work in your RAA system, one of the best systems out there, are ACEs that work right here, ARBs that work right here, and spironolactone. Moving on from there, let's talk about calcium channel blockers. And when you think of calcium channel blockers, think of calcium as a squeezer. Okay, calcium is usually I think about muscles, and you need calcium for muscle contraction. I think about calcium as a squeezer or muscles, but also for cardiac conduction, because we're going to talk about that later. So calcium squeezing muscles. And you know, if you remember how hypocalcemia, the Chavasse-Dex and Trousseau side are all about muscle twitching. Calcium channel blockers are used to treat angina, dysrhythmias, and hypertension, as well as some other disorders that are characterized by vasospasm. They are considered selective or non-selective. Selective calcium channel blockers are going to vasodilate, and they're your dipines. So nifedipine, nicardipine, and amlodipine. If you see dipine, it is a calcium channel blocker. There's two non-selective calcium channel blockers who I like to say don't play well with others. They're not dipines. And these two medications are used for both blood vessels and heart. We're going to talk about diltiazem as it relates to uncontrolled atrial fibrillation. So diltiazem or cardizem is often used not only for hypertension but also to slow a rapid heart rate, as is verapamil. Right now, diltiazem is one that's a little bit more popular. Things to consider: flushed skin and dizziness, peripheral edema, myalgias, sexual dysfunction, impotence, constipation. Okay, if the patient has a large weight gain, they should report it. Okay, that's kind of across the board anyway, except if it's like Super Bowl Monday and you've been eating junk food. Then you might have 2.2 pound weight gain, but it's not related to any kind of medication. Okay, moving on. Vasodilators. Okay, there are some things that are direct vasodilators. Hydralazine, isosorbide dinitrate. Now these both work a little bit differently. Okay, the nitrates we know are actually they both work the same. They directly relax blood vessels. So if you see hydralazine or isosorbide dinitrate. We talked in class about nitrates, and nitrates are coming back later on in one of the videos when we talk about angina treatment. And nitrate's job is to vasodilate. It can be used to drop blood pressure. So for clients that can't take ACEs, you can use these guys. But once again, anytime you vasodilate, you have to worry about orthostatic hypotension. You may have been wondering, where are the betas? Okay, the betas are here. Because the betas work in a different system, we lump them into this system. Adrenergic antagonists. One thing that's crazy about taking care of people and learning things is that there's so many different words for things. So adrenergic is your sympathetic nervous system. Antagonists are your blockers. So these are things that are going to block sympathetic stimuli or blocks the actions of the SNS on those receptors. So if you go back to that diagram that I put up there with your alpha 1, your alpha 2, your beta 1, and your beta 2, we're going there now. All right, hold on, here we go. Beta blockers. Okay, you see these all the time. Okay, these are your ALOLs, beta adrenergic blockers. The mechanism of action is to block beta adrenergic stimuli. So they're going to block these receptors here from attaching and causing the increased heart rate, the increased contractility. So what they do by blocking is decreasing heart rate and decreasing contractility. By doing so, we'll decrease the blood pressure through a reduction of cardiac output and decrease the workload of the heart. Beta blockers can be used in a lot of things. You may see it in hypertension, but you're also going to see it in patients with angina and MIs to decrease cardiac workload, because remember, chest pain is an imbalance between oxygen supply and oxygen demand. Beta blockers will decrease your demand. You may also see it for dysrhythmias, and they also have a pretty large role in the treatment of heart failure. Non-selective and selective. Okay, you know, on the diagram we talked about beta 1 affecting the heart and beta 2 affecting the lungs. So non-selective beta blockers are going to block both beta 1 and beta 2, which means you're also going to block that bronchodilation. So non-selective beta blockers, you have to watch a little bit for wheezing. So these are the list of your non-selective, and then you've got cardioselective. Cardioselective are specific to beta 1. So atenolol and metoprolol are both cardioselective beta blockers, which means that there's less of a chance of having the bronchoconstriction. What I want you to think about is if you see the lols in a question and there's something relating to wheezes or lung sounds, I want you to think about making that connection that there may be some bronchoconstriction going on. Okay, listening to lungs. Okay, very, very important. And it's often a connection you don't think about because you're thinking all about heart rate and blood pressure and blocking your betas and all that stuff. Listen to the lungs. Beta blockade is going to cause fatigue, and sometimes patients will say, I can't stand my beta blockers, they wear me out. A lot of times if they're ordered daily, you can tell them to take them in the evening. Right? They're still going to work, and it may help a little bit. It's going to decrease your libido, right? And depression. Beta blockers as an off-label use sometimes are used by people who are stage actors to decrease stage fright because it's going to block that sympathetic nervous system. The downside is it can make you depressed. Okay? It can cause erectile dysfunction. Okay? And the two biggies are bradycardia and bronchoconstriction. Okay? Thing with beta blockers, you do not want to abruptly stop taking beta blockers. Okay? Why do you think that is? If you said maybe because the blood pressure goes up, you're correct. It's going to cause a rebound hypertension. The other thing to think about beta blockers is oftentimes in somebody with diabetes, because of all of these things, you may have masking of the signs and symptoms of hypoglycemia. So patients may get hypoglycemic and not have some of those signs and symptoms because their sympathetic nervous system has been blocked. I know on the ATI pharm practice there is a question about beta blockers and the fact that it masks the symptoms of hypoglycemia. Okay, prototype, metoprolol. Mechanism of action, block the cardiac action of the sympathetic nervous system in slowing heart rate and blood pressure. Okay, you can read through the adverse effects. Carvedilol, or Coreg, is a medication that's often used specifically in patients with heart failure. And it's got a little bit of alpha and beta effects, so it's a little special. That's why it's kind of on its own down here. Let's talk about alpha-1 blockers, the alpha-1 adrenergic antagonists. These are your azosins. Okay? Cardora is an example. It's doxazocin. There's also prazosin, which I believe goes by the brand name of apresilene. I could be wrong. Its job is to block alpha-1 sympathetic receptors. And if you remember, alpha-1's job is to vasoconstrict. We want to block that. So ideally, it's going to have a vasodilatory effect. Uses in hypertension. The problem is it may cause an orthostasis or dizziness, so you have to watch with that. Alpha-2 agonists. They don't do as much. You don't hear about alpha-2 as much. It's kind of like the redheaded stepchild. Remember, alpha-2 works in the presynaptic receptors. So before norepinephrine even gets out there to cause problems, it's going to decrease it. It decreases the norepinephrine so it can't go across the synapse and go to your alpha and beta receptors over here. It stops it at the source. So clonidine and methyldopa are alpha-2 adrenergic agonists. Okay? And instead of an antagonist, it's not blocking, it's potentiating the effect of alpha-2. So clonidine and aldomet, or methyldopa, are actually increasing the blockage or increasing the work of alpha-2. Direct vasodilators, I believe we talked about before. It got thrown in here as well. Okay, vasodilation by direct relaxation of smooth muscle. This is a nifty little drawing that kind of shows the different areas that the alphas, the betas, the calciums, the ARBs, the ACEs all work with respect to your cardiovascular system. Okay. I'll try and get a PDF to post in Blackboard for you all to use. So let's finish up with the nursing process, and then we'll move on to our next subject. Okay. And this is important. You want to take the blood pressure in each arm for a baseline, because blood pressure can be different from arm to arm. You need to assess a heart rate apically. Take the time. It's a minute. It's a minute of your life. It'll be worthwhile, because if that patient has any kind of vascular disease, you can't guarantee that that radial pulse is going to be accurate. Make sure that you're looking at weights and heights. Always check your labs before you give your meds. Okay? If you don't have something from today, look and see it yesterday. If there was an abnormality, was it treated? Monitor for adverse effects. Okay, you know the common ones. So your responsibility after you give those medications does not go away. Your responsibility, as long as you're there caring for the client, is to make sure that you're monitoring for those adverse effects and rechecking your blood pressure. Okay, monitoring renal. Okay, doing assessments with history, lifestyle, medications, lung sounds. Got to watch those lung sounds, and any change in mental status. We're going to stop here, and the next video will discuss medications specifically to coronary artery disease. Thank you so much for your time and attention.